Alright, so here is the plan now. We're going to go a little bit more into acid-base balance because I want to know more about it. So there's a couple of videos that registered nurse are in this. So we're going to watch these. I'm going to put them on 1.5 times, kind of watch them.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to be going over respiratory acidosis. I'm actually doing a series on acid and base imbalances, so if you're studying that right now, be sure to check out those videos. Now in the previous video I went over respiratory alkalosis and showed you the differences, how it affects the body, what to remember for the NCLEX exam and your nursing lecture exam, so be sure to check out that video. So in this video, what I'm going to do is I'm going to simplify the pathophysiology with what's going on in respiratory acidosis. I'm going to give you a mnemonic on how to remember the causes, and we're going to go over signs and symptoms, nursing interventions, and then I'm going to take it a step further and work a arterial blood gas problem with a patient that's in respiratory acidosis and show you how to set the problem up.
Sounds dope so far.
Using the tic-tac-toe method and how you can determine if it's compensated, not compensated, and things like that. Now, for this video, go to my website, RegisteredNurseRN.com, and take the free quiz that will test your knowledge on respiratory alkalosis and respiratory acidosis. A card should be popping up or a link in the description below, and you can access that free quiz. So let's get started with the pathophysiology, because in order to truly understand what's going on in the body during respiratory acidosis, you have to know what is being affected in the lungs. Then the causes will make sense. It'll literally be like common sense, and it'll click in your brain. So let's simplify. Hey everyone, it's Sarah with Registered. Whenever you breathe, you take in oxygen through either your nose or your mouth. So the oxygen enters in through there, the pharynx area. Then it goes down through the larynx, which is your throat, down through the trachea, which branches off into the bronchus, which then branches off into the bronchioles, and then to the alveolar sacs, is where everything, the gas exchanges are happening. And what happens is that oxygen enters in and carbon dioxide comes out, because carbon dioxide is that buildup of whatever your body has left over, and you're going to breathe that out. So the carbon dioxide will go backwards of how the oxygen entered, and it will exit through your nose or through your mouth. Now in those alveolar sacs, what's happening is oxygen is going into those sacs, carbon dioxide's coming out, oxygen's attaching to the red blood cells. The red blood cells are transporting it throughout your body, to your organs, to your tissues, and giving it fresh supply of oxygen. But whenever you have something that's interrupting the breathing, either you have depressed respirations where maybe you gave them an opioid, they have too much drugs involved or something like that, it causes depressed breathing, they're not expelling the CO2. So anything that's affecting the body's ability to breathe normally, because in an adult, normal respirations are 12 to 20 breaths per minute. So if it's less than 12, they're not breathing appropriately, so they're not expelling the CO2. And we'll go over the causes a lot more in depth. And your diaphragm, which is below your lungs, plays a role in this as well. So if you have anything that affects the diaphragm, which in neuromuscular diseases, which we'll go over here in a second, that can affect, because whenever you breathe in, diaphragm goes up, helps squeeze that air out, squeeze out carbon dioxide out, and then it relaxes. So if you have anything affecting that, that can cause problems. So whenever you have the buildup of the CO2, this causes your blood pH to become acidic. And here are some key concepts that you need to remember for this disease process that your teachers will probably ask you on exams or on the NCLEX. So let's look at these key concepts. Okay, overall, respiratory acidosis is the buildup of carbon dioxide in the blood. And it's mainly due to bradypnea, which brady means slow, pnea deals with respiration. So you're having really slow respirations where you're not getting rid of that carbon dioxide. And what happens? Carbon dioxide's in your body, there's too much of it, and your body's like, oh, we do not like this. So your blood pH, because of that carbon dioxide, causes the blood to become very acidic. And it will become a pH of less than 7.35. And you remember, you have a lot of carbon dioxide, CO2 hanging around. So the levels are going to increase. So anything greater than 45. Now, whenever this happens in the body, remember your body loves homeostasis. It loves to keep everything nice and equal. So it'll use other systems of the body to try to regulate this out. So the kidneys will actually start to release bicarbonate, HCO3, and you will start to see these levels rise. And the reason that they're trying to rise is to help decrease that pH, help to increase that pH level, to make it normal, because right now it's decreased and they want to increase it. So by releasing the bicarb, it will help hopefully increase it. And any levels greater than 26, if you see that in a blood gas, that's what your body's trying to do, is trying to compensate with that. Now, you want to memorize these lab values. You seriously just want to commit these to memory so you can understand what's going on, because whenever you're solving blood gas levels or anything like that, you're going to have to refer back into your memory, hey, what's normal, what's acidotic, what's not. So let's go over it real fast. A normal pH level is 7.35 to 7.45. A normal PaCO2 level, your carbon dioxide level, is 35 to 45. How I remember these two, remember the 5s at the end? 7.35 to 7.45, and then again PaCO2 is 35 to 45. You see the 3 and the 5 and the 4 and the 5. And then the HCO3, which is your bicarb, the normal is 22 to 26. And then I just have this little chart. This helps me remember it if it's an acid or not an acid. And for pH, anything acid right here, anything less than 7.35 is an acid. Anything greater than 7.45 is a base, alkalotic. And PaCO2 is the opposite. So the high number, anything greater than 45 is acidotic, and anything less than 35 is alkalotic, and bicarb, anything less than 22 is acidotic, and anything greater than 26 is alkalotic. So just try to remember that, because that's going to help us whenever we try to solve our blood gases, and I'm going to show you how to do that using the tic-tac-toe method. Okay, so let's go over the causes of respiratory acidosis. Okay, Remember this mnemonic, the word depressed breathing, because that is one of the big reasons why your body is becoming acidotic, why you're having that buildup of CO2. So remember the word depressed, and each word will correlate with what the cause is. Okay, first, drugs. Any drugs such as opiates, which are morphine, fentanyl, questions like to throw that out at you, say the patient overdosed on morphine or fentanyl or something like that, or any sedatives such as Versed, that's a lot of times given during moderate sedation, will cause respiratory depression. And remember, when the patient is breathing less than 12 breaths per minute, they're just barely breathing and they're not expelling that CO2. That CO2 is building up. So that can cause respiratory acidosis. So you want to watch patients with that. Also, the other D, diseases of the neuromuscular system. I talked about this at the beginning. This is the myasthenia gravis or Guillain-Barré syndrome, and this is weakness of the voluntary muscles, like the diaphragm, which helps to squeeze that carbon dioxide out. And in these syndromes, they're not working properly, so they can't expel that carbon dioxide. It's hanging around in there. Okay, E, edema. Anytime you get extra fluid in these lungs, like in pulmonary edema, especially with congestive heart failure patients, that fluid is hanging around those sacs. And remember, in the alveolar sacs, we talked about how there's a gas exchange between oxygen and carbon dioxide, and it messes up those sacs. Those sacs can't open and close properly, so it just starts to retain the CO2, so that can cause it. Next, pneumonia, almost the same concept as the fluid. With pneumonia, you have that excessive mucus production around those sacs, and your sacs are filled with pus and fluid, and they're not able to even properly inflate and deflate, so you have that buildup of that carbon dioxide that your body's trying to get rid of, so pneumonia can cause it. And next one, the R, respiratory center of the brain is damaged. Okay, in your brain, you have the medulla and the pons area. That is responsible for your respiratory center. Now, if you have any traumatic brain injury or you had a stroke that affects that area, that can affect the way that the patient breathes, how they take breaths. So they can develop respiratory acidosis. Okay, E for emboli. And this can block the pulmonary artery or the branches of the lungs, depending on where the emboli left the body. This can be a fat emboli, air emboli. It can go into the branches and block all. So if you have something blocking off that branch, whenever you're trying to get that oxygen into that alveolar sac, it can't go. So if it can't go, carbon dioxide can't go, and carbon dioxide is just going to stay and hang out in the blood. So that can cause problems. So anything blocking in the lungs can cause those issues. And the other S, spasms of the bronchial tubes. This is asthma. Whenever a patient has an asthma attack, these bronchial tubes start spasming, which is blocking, again, just like the emboli, the gas exchange. And what is going to happen is that patient, whenever they're having that, they're not taking those nice deep breaths, and they're building up that CO2. Okay, and the last S, this is another important S. What is happening with this is that you have the sac elasticity of the alveolar sac is damaged. And what's happened is that this sac is damaged either because of a disease process called chronic obstructive pulmonary disease, COPD, or emphysema. And what happens is whenever this sac is damaged, it's usually due to smoking. So that's why healthcare providers really encourage patients to quit smoking, because they're taking the smoke goes through the lungs and it damages those sacs. And what happens is that the sac becomes damaged and it doesn't properly deflate. So whenever it doesn't properly deflate, it retains CO2. That's why you'll hear patients who are COPD patients, they're CO2 retainers, because that sac is not deflating properly and it's keeping all that carbon dioxide. Now, let's look at the signs and symptoms, the nursing interventions, and work an arterial blood gas problem and show you what a patient with respiratory acidosis would look like. Okay, how does your patient present and look whenever they're in respiratory acidosis? Normally, this is going to start to happen gradually, and you'll start to see a neuro decline, neuro changes. All of a sudden, they'll become confused, maybe not answer your questions appropriately, and they'll just nod off and fall asleep. I remember I had a patient one time. He was starting to go into this, and we would be talking, and all of a sudden he would literally fall asleep right in front of my face. And we checked his ABG levels, and sure enough, he was in respiratory acidosis. So really watch your neuro part. Also, the patient may say, I just have a headache, and then they're confused and they're drowsy. That should send a red flag too. And of course, respiratory depression. They're going to have a really slow respiratory rate, less than 12 breaths per minute. So make sure as a nurse you're counting those respirations appropriately and monitoring those. And have low blood pressure as well. Okay, so what do you typically do for a patient who is in respiratory acidosis? Of course, you'll contact a doctor. They'll give you a lot of orders on what to do, but typically this is what's going to happen. You're going to administer oxygen, and if the patient is alert enough, you're going to encourage coughing and deep breathing, helping them take those full deep breaths in and out. Because remember, we want them to expel that carbon dioxide that's built up, so we want them to be taking normal breaths at a rate of at least 12 to 20 breaths per minute. And if the patient has been having asthma attacks, COPD, or emphysema, a respiratory treatment might be good, so get respiratory therapy involved to give them a treatment, help with that, bronchodilators, because remember in asthma you have bronchoconstriction, and that'll help open them up and so they can breathe properly and have that gas exchange go so they can expel that carbon dioxide. And also, if your patient is in this, a lot of times narcotics will cause this, morphine, fentanyl, even Lortabs, things like that, anything that's an opiate or a sedative like Valium. Things like that can cause respiratory depression. So you'll want to hold those medications. Don't want to give those because it will make it worse. Now, remember this is very, very, very important. Watch potassium levels with respiratory acidosis. We talked about this in the hyperkalemia fluid and electrolyte series because this will cause an increase of your potassium levels, anything greater than 1.5. So you want to watch that. Whenever you get hyperkalemia involved, you need to watch for any EKG changes that's associated with hyperkalemia, which are tall.
So respiratory acidosis is going to increase your potassium, and that's going to start affecting the heart when it gets
all T waves, the flat P waves, or a prolonged QRS and PR interval. So watch for any of that. Now, if the patient has pneumonia, you'll be giving antibiotics, encourage incentive spirometer usage so they can breathe in, pop those sacs open, which have the mucus and the pus in them, so you can help gas exchange. And if it's really, really bad, the CO2 level, whenever you draw your blood gas, if it's greater than 50, the doctor may order the patient to have endotracheal intubation. So prepare the patient for this, or if they're in respiratory distress. So that is the nursing interventions for that. Now, let's work a problem that will show you how to do a blood gas problem on a nursing exam or the NCLEX, because this is what nursing professors love to ask you whenever they're going over acid-base imbalances. They're going to throw some ABG values out at you, and they're going to give you some options, and you have to decide what it is. So I like to do the tic-tac-toe method whenever I'm solving ABG problems. I have two videos on where I go in depth on how to use the tic-tac-toe method, setting up your problem and solving that. A card should pop up, a link should be in the description as well, so you can watch that video on how to do that. Okay, what's acidotic, what's base, these back to 48. Okay, we're thankful. And anything 5 to 7 points are dealing with, and then is this at all? So remember at the beginning of this lecture, we talked about how whenever there's a buildup of CO2 in the lungs, the kidneys are going to try to fit because it wants to go or bicarb.
So that's that one. Now we're going to watch metabolic acidosis, see what we can learn here.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to be going over metabolic acidosis. In the next video I'm going to be covering metabolic alkalosis, so if you're studying this material, be sure to check out that video because I am doing a series on acid and base imbalances. So in this video, what I'm going to cover is I'm going to cover a little bit of the patho behind metabolic acidosis and break it down for what you need to know as a nursing student and what you need to know for the NCLEX exam and your nursing lecture exams. Then I'm going to go over the causes of metabolic acidosis and give you a clever mnemonic on how to remember those causes, then the signs and symptoms. How would you see a patient? What are they going to appear to have whenever they're in this condition? And then the nursing interventions. And then lastly, I'm going to follow it up with an arterial blood gas problem in solving for a patient who has metabolic acidosis and how to show you to find out if it's compensated, partially compensated, not compensated, and things like that. So let's get started. First, what we want to do is we want to go over the patho of this condition. This can get really, really in-depth, but as a nursing student who's needing to take the NCLEX or nursing exams, I'm going to simplify it for you and tell you what you need to know specifically. Okay, so metabolic acidosis, what is this? Well, in the previous videos, we talked about respiratory acidosis and respiratory alkalosis. Those were respiratory issues going on in the lungs. The CO2 issues were thrown off and it's causing the body to do all these crazy things. Here, we got some metabolic problems going on. And we know, since it's acidosis, we got acid issues. So we got metabolic problems going on with acid. So pretty much what's happening in the body, there's too much acid built up in the body fluids, which is causing the HCO3, which is bicarb, to decrease. It's plummeting. So remember this, anytime you have increased acid production in the body, your bicarb levels are going to plummet. And
high acid, low bicarb.
Put them into metabolic acidosis. Now, what are some things that cause metabolic acidosis? And here in a second, we're going to go into it in depth, but these are usually the three categories. First category, you just have way too much acid being produced in the body. And this happens, for example, in DKA, diabetic ketoacidosis, hence the ketoacidosis part. And this is what's happening is that patients' blood sugars are crazy high. They're producing a lot of ketones. Ketones are an acid, and it's building up in the body, and it's causing the bicarb to just plummet, to go down. Other thing, there's a decrease of acid secretion. So what is responsible in your body for normally filtering out all those nasty waste products? Your kidneys. So if your kidneys aren't working good, like in renal failure, they're not filtering all those byproducts, the waste out. So you're going to keep all that acid. Whenever the acid increases, the bicarb plummets. So the bicarb just can't regulate that imbalance of all that waste on board, so it just falls. Next, another third cause is loss of bicarb. You're losing it. How would you be losing it? From diarrhea, because diarrhea, those secretions have a lot of bicarb in them, and whenever you're just having profuse diarrhea, you're losing all that, and all that acid is building up in the body. So in turn, what will happen is that lab values, your arterial blood gases, are going to be thrown completely out of whack. And the body is going to try to compensate. Just like in respiratory alkalosis, acidosis, we talked about how the kidneys try to compensate for those problems going on. Now here, whenever you have metabolic acidosis, your respiratory system tries to compensate because it's like, hey, there is way too much acid here in the body, and we got all this CO2 in our lungs, which is an acid, so let's breathe a lot more rapidly. Let's hyperventilate to expel this CO2 so we can hopefully increase that blood pH back to normal and increase that bicarb level. So that's what it's hoping to do. So you're going to see patients whenever they're in really bad metabolic acidosis, their breathing rate is really going to be, they're going to be breathing. And the type of breathing they'll be doing is the Cosmal breathing. This is deep, rapid breath.
Kuzma breathing with metabolic acidosis. Okay.
And what your body's just trying to do is trying to expel all that CO2 because it's like, hey, this is way too much acid. Let's get rid of this. So this will throw your lab values off. So when a patient who's in metabolic acidosis, you're going to see these following lab values. You will see a blood pH of less than 7.35, and that is because you have all these acids on board, and that is what happens. The pH drops. And a normal blood pH is 7.35 to 7.45. So anything less than 7.35 is an acid. Your HCO3, which is your bicarb, will be less than 22, because remember, it just plummets whenever you get all these acidotic conditions. And a normal bicarb level is 22 to 26. And your PaCO2, which is your carbon dioxide level, is also going to decrease, or it could stay normal. If it's not, the body's not compensating yet, it'll be normal between 35 to 45, but if it is trying to compensate, it will drop, because remember, it's trying to expel all that CO2. So it'll be less than 35. So now let's look at the causes of metabolic acidosis. Okay, before we get into the mnemonic, let me lay the framework, because
anion gap, remember our class, it's 3 to 12, and if it's greater than 17.
In order to treat as the doctor who is going to be treating it, we need to look back at this so we'll know why the doctor is ordering these certain orders, how they know it's this type of metabolic acidosis. So let's just lay the framework for this, and then we'll go into the exact causes. Okay, there are two different types of causes of metabolic acidosis. You have a high anion gap or a normal anion gap. And the reason that it's so important to know if the patient is in a high anion gap or a normal anion gap is so the doctor can treat the cause, because if they don't figure out exactly what's causing it, like for instance diabetic ketoacidosis, which is a high anion gap, and they don't treat that correctly, this is life-threatening and the patient can die. So they have to pinpoint the cause in order to order the proper treatments. So what in the world is an anion gap? Simplified for what we need to know as nurses, this is where the doctor looks at various lab values in the patient's blood work, for instance electrolytes like chloride, bicarbonate, and sodium, and they calculate this to see the difference between the anions and the cations. And they're looking for this gap. And if there is a gap in between this calculation from the normal, greater than 14 milliequivalents per liter from the normal, which a normal anion gap is 10 to 14 milliequivalents per liter,
3 to 12,
this means that it's a high anion gap cause. So they calculate it, they get a value greater than 14 milliequivalents per liter, it's a high anion gap. So high anion gap acidosis, what conditions cause it? We'll go over that here in a second. But typically, what causes it is where the body starts to produce too much acid and not enough bicarb. So, for instance, diabetic ketoacidosis. There's too much acid in the body and bicarb's dropping. So that's a high anion acidosis. What are causes of the normal anion gap acidosis? These are any conditions that cause your body to just lose that bicarb, like in diarrhea. Okay, so how do you remember all that? I wanted to take the high anion gap and the normal anion gap and just put them together to help you remember it as a nursing student. So what we're going to do is we're going to remember the mnemonic.
So a high anion gap, you're making more acid than bicarb, but a normal anion gap, you're losing bicarb. So those are like conditions. Okay.
Chronic acidotic. We're in acidotic conditions, so that's easy to remember, and each letter will correlate with the cause. So let's get started. Okay, A for aspirin toxicity. This is a high anion gap, because what's happening is whenever a patient either accidentally or on purpose, like in a suicide attempt, takes a whole bottle of aspirin in the body, all that aspirin is going to enter into the gut, and the body's going to absorb it, and it is just going to increase all of the acid in the body. And whenever that happens, you start getting hyperventilation, and you also get respiratory alkalosis, which we talked about that in the respiratory alkalosis. That was one of our causes. So aspirin toxicity, taking all the aspirin is going to increase the acid in your blood. Okay, C for carbohydrates not metabolized. There are conditions where patients, people have issues metabolizing carbohydrates, and whenever this happens, there's not enough oxygen to break down those pyruvic acids. And pyruvic acids, what they are, they supply energy to the cell. But the oxygen is not allowing us to break those acids down. So whenever those acids don't break down, they start to turn into lactic acid. And whenever you have buildup of lactic acid, it throws the body off. And that's going to cause your bicarb levels to plummet. Okay, I for insufficiency of the kidneys. And this is a high anion gap metabolic acidosis, just like the carbohydrates was as well. I didn't say that in the other one, but carbohydrate, not metabolizing carbohydrates, is high anion gap metabolic acidosis. But with insufficiency of the kidneys, like I talked about at the beginning of the video, the kidneys aren't filtering out the waste in the blood. So this increases acids. Remember, when acids increase in the body, your bicarb falls. Okay, D for diarrhea. Okay, your GI fluids and your pancreatic fluids, all those fluids are rich in bicarb, HCO3, alkalotic fluids. And whenever you're losing a lot of that, you're going to increase the acid because you've got rid of all the alkaline fluids, so what's left over is the acid. So that, again, is going to make your bicarb drop. And then the other D, just to help you remember, the other D is DKA, diabetic ketoacidosis. Remember, you have too many ketones on board, which are an acid. It's all over the body can't compensate, so what happens is that the bicarb levels fall. Okay, O for ostomy drainage, and this is a normal anion gap one, just like the diarrhea is a normal anion gap, because again, that's where the body is losing too much bicarb. So with the ostomy drainage, you need to pay attention to especially ileostomies, because these fluids are rich in bicarb. And normally, whenever stuff travels through your body, out through your stool, the stool is low in bicarb because the body's absorbed it, regulated it. But whenever you have an ileostomy or other ostomies, you're stopping at a certain point. So if you're having excessive drainage come out, all that fluid is really rich in bicarb, and it's not going to pass normally through the gut like it's supposed to. So you have to really watch these patients who do have ileostomies for metabolic acidosis because we're going to lose a lot of bicarb through there. So you have to watch that. Okay, T for fistula. We'll use the T in fistula. And this is like the same concept as ostomy. Fistulas are where you have a hollow passage either between an organ and the body surface or between two organs where fluids are going through. And normally that's not supposed to happen because those fluids are supposed to stay and go and be transported throughout the body where they're supposed to go. So they are, again, just like ostomy drainage, rich in bicarb. They're alkalotic. So if you're losing them somewhere, you're not needing to lose them, you're definitely at risk for developing metabolic acidosis because you're losing all that alkaline fluid, which increases the acids. Okay, and I for intake of a high-fat diet, this is a high anion gap, and this is where if you are consuming way too much fat in your diet, you're not having a good balanced diet, you're just eating a lot of fat, what happens is that you're going to have increased waste and acids and ketones in your body, and your body's not going to be able to compensate for all this fat, acids, all that nasty stuff on board, and it's going to cause the bicarb to decrease. Okay, and last, C for carbonic anhydrase inhibitors. These drugs, remember this is a big one. For instance, Diamox. Diamox is a diuretic, and we will be talking about this in metabolic alkalosis. It's actually a treatment for metabolic alkalosis, so remember this drug, Diamox. It's a carbonic anhydrase inhibitor. And what happens is this is a diuretic, and it causes to decrease the reabsorption of bicarb. So the patient's urinating, and to urinate, it's causing you to not reabsorb that bicarb. So if a patient's been taking way too much Diamox, or their body hasn't been responding appropriately to it, they're definitely at risk for metabolic acidosis. So now let's talk about how your patient's going to look, the nursing interventions, and then let's work an ABG problem. So how are these patients going to look to you as the nurse? What are they going to have signs and symptoms wise? Okay, the first thing that you just want to remember out of this whole signs and symptoms area is the cosmal breathing. This, remember was the body's attempt in the respiratory system to try to compensate for those acidic conditions by blowing off that CO2, which is an acid. So they're going to have deep and rapid breathing, greater than 20 breaths per minute, up into the 40. So that is a big sign, especially in diabetic ketoacidosis. They may also be weak, confused, have a low blood pressure, and they could have cardiac changes. And this is due to the increased potassium, hyperkalemia. We talked about this in the hyperkalemia video, so be sure to check out that video as well. And nausea and vomiting. So what are you going to do for this patient as the nurse? Well, it totally depends on what is causing this. Is it diabetic ketoacidosis? Is it diarrhea? Is it renal failure? So depending on what's causing it will vary your treatment. But what you need to do with all of these conditions is watch for respiratory distress. And this is coming from cosmal breathing. If that patient blows off so much CO2 and drops those levels less than 35, they can be in really big trouble. So they may need some intubation, mechanical ventilation.
So low CO2, like real low.
Watch those other electrolyte levels, especially the high potassium levels, because whenever metabolic acidosis is actively going on, they're going to.
So it seems like every time you go acidic, your K goes
have high potassium levels. But whenever you're starting to correct it, you have to watch out because you can flip them into hypokalemia.
But then if you correct it, you might flip them into hypokalemia.
Because what's happening is that potassium is going to go back into that cell. So all that potassium was in the blood in hyperkalemia is going to shift intracellularly and cause hypokalemia. There's not going to be any potassium left in the blood because you're trying to correct the state. So you need to watch out.
So we're already hyperkalemic because there's a lot of crap in the blood. But then when you switch it, the K goes back in the cell, and there's none in the blood.
For that as well. And their neurostatus and seizures may put them in seizure precautions. Okay, now I just want to discuss if the patient was in renal failure. One thing you need to do is you need to get strict I's and O's, intake, output, things like that. Be watching their urinary output, be watching their other lab values, because whenever a patient's in renal failure, they can have high potassium, high BU and creatinine. You really got to watch those levels and watch their diet, what they're eating, how much fluids they're drinking. And also the patient may be a candidate for dialysis to go in to remove that extra waste, acids off the body and help correct this. Now, if they are in DKA, diabetic ketoacidosis, typically what will happen is that the doctor will order you to start them on like an insulin drip maybe, where you'll be titrating insulin, giving them, watching their blood sugars very, very closely. And what's going to happen is that insulin is going to act as a little transporter and help take that glucose back into the cell, which will help the body to start metabolizing the glucose correctly instead of metabolizing those ketones, which it was breaking down ketones. When you break down the ketones, it goes in the body, increases the acid, which throws them in metabolic acidosis. So, you may be doing that if the patient's in that. Okay, so now let's work in our...
No, let's not do that, brother. All right, third one, gonna be respiratory alkalosis.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video, I'm going to be going over respiratory alkalosis. Right now, I'm doing a series on acid and base imbalances, so if you're studying this in school, be sure to check out those videos. Now, in the previous video, I went over respiratory acidosis because there are some differences in these two conditions. So in this video, what I'm going to do for you is I want to highlight the things you need to know for NCLEX and for your nursing lecture exam. So I'm going to be going over the key concepts. So what I'm going to do is I'm going to simplify the patho, because if you can understand the pathophysiology, you can understand the causes and why the patient has those signs and symptoms and what are the nursing interventions for the patient. Why are you doing those? It all makes sense. Then I'm going to follow it up and work a arterial blood gas problem for you with a patient who is in respiratory alkalosis and show you how to set it up, and I'm going to use the tic-tac-toe method. Now, after this video, be sure to go to my website, RegisteredNurseRN.com, and take the free quiz that's going to test your knowledge on respiratory alkalosis and respiratory acidosis. A card should be popping up or a link in the description below so you can get that free quiz. Okay, first let's look at the pathophysiology of this and simplify it. Okay, whenever you have respiratory alkalosis, the problem is in the lungs, specifically in these little alveolar sacs. But first, let's talk about what's going on when you're breathing in air and expelling air. Okay, what happens is that you take oxygen in through your nose or in through your mouth, and it travels down to your pharynx, then down through your larynx, which is your throat, then down through the trachea, which branches off into the bronchus, your right and left bronchus, then that branches off into your bronchioles, and then that branches off into your alveolar sacs. Now, in that sac is where gas exchange is happening. So you just took in all this fresh oxygen, and that's going to go across that sac and attach to a red blood cell, which a red blood cell is going to transport it through your body and supply your muscles, your tissues, all that with that nice oxygen. But your body is trying to get rid of the carbon dioxide that's built up in its body. So the carbon dioxide will go across that alveolar sacs membrane, and it will travel the opposite direction of what oxygen did, and you will expel it out through your nose and through your mouth. Now, a normal adult breathes 12 to 20 beats per minute, and breaths per minute, and that is a good amount of breathing to get rid of this this carbon dioxide. So anytime you have something that's messing with how much you're breathing or anything like that, it's going to affect how much carbon dioxide you are getting rid of. So here, these are key concepts you want to remember. You are expelling way too much carbon dioxide, and you're doing this due to tachypnea. Tachy means fast, pnea deals with respiration, and you're probably breathing more than 20 breaths per minute, so you're just going hyperventilating, and what you're doing is you are just pushing all that carbon dioxide out. And your body does not like that. So whenever you're getting rid of all that carbon dioxide, what happens is that your pH in your blood starts to increase. You're starting to make your blood alkalotic, basic. And any value greater than 7.45 is alkalotic. But your PaCO2, which measures your carbon dioxide levels, start to decrease. And the reason they're decreasing is because you're blowing it all out of your lungs. It's going away. So the level will be less than 35. Now, the body doesn't like this. And remember, as we always talk about, the body loves to be in a homeostatic environment. It likes everything to be normal. So it will try to use other organs of the body to help fix problems that's going on. So the kidneys start to play a role in this. And what the kidneys will do to try to compensate is that it will cause the kidneys to start getting rid of all this bicarbonate, to just flush it out of the body. So you're going to be urinating all this bicarbonate out, which is HCO3. And the body hopes by doing this, it will decrease that pH, which is alkalotic right now. Because remember, your pH is high, it wants to get it down. So it thinks by getting rid of all that bicarbonate, it will help do that. So you want to memorize these lab values. Commit these to memory, because whenever in nursing school, they love to give you blood gas analysis problems and ask you, is this respiratory alkalosis, acidosis, is it compensated, partially compensated, things like that. So commit these to memory, and I'm going to go over them with you real fast. Okay, a normal blood pH is 7.35 to 7.45. A normal PaCO2, which measures your carbon dioxide levels, is 35 to 45. And a normal bicarb, which is measured in HCO3, is 22 to 26. And you need to know which values are acidotic and which are alkalotic. So I have this little table to help you remember. Anything less than 7.35 in a pH is an acid, and anything greater than 7.45 is basic, alkalotic. Okay, for PaCO2, measuring your carbon dioxide levels, it's the opposite. The higher number is actually acidotic, so anything greater than 45 is an acid, and anything greater than 35 is basic. Anything less than 35 is basic. And for bicarb, anything less than 22 is an acid, and anything greater than 26 is a base, so it's alkalotic. Okay, so let's look at those causes of respiratory alkalosis. Okay, so we've established that you're breathing too much, you're breathing way too fast, you're hyperventilating, you're having tachypnea. So let's remember the mnemonic tachypnea, because that is a big cause for why you're having respiratory alkalosis. So each letter will correlate with a cause. Okay, so T stands for temperature increase in the body, aka fever. What happens is whenever you have a fever, this is increasing the metabolic needs of your body. And to compensate for that, your lungs, your respiratory center, tries to increase the respiratory rate. So what you're going to be doing while you have a fever, you're going to be hyperventilating, you're going to be breathing way too fast, and you're going to be getting rid of that carbon dioxide. So that can cause a fever. A for aspirin toxicity. Remember this. A lot of tests like to ask about this. They may give you a scenario about a patient who ingested a whole bottle of aspirin, and what condition are they at risk for. So remember this, and why this causes respiratory alkalosis is because whenever you have too much aspirin on board in the body, it causes the body to go in hyperventilation mode, because it simulates that respiratory center in your brain, the medulla and the pons, to breathe faster. It also causes a fever, which we just learned that fever causes respiratory alkalosis. It causes a lot of bad things to the body. It also increases your decreases your potassium levels, and makes you go into metabolic acidosis. So that can cause respiratory alkalosis. C for controlled mechanical ventilation. Patients who are intubated are definitely at risk for respiratory alkalosis. Remember this. This is another test question that NCLEX and professors like to hit on. They'll say that the patient has these following blood gases, and blood gases will be respiratory alkalotic blood gases, and they'll say which patient below would you expect to maybe be at risk for having these type of blood gases. So remember this. The reason that these patients are at risk for this is because they have a machine that's controlling how much they're breathing, how much controls the rate of their breathing, and what can happen is that you can hyperventilate the patient and cause them to take in too much oxygen and deplete too much CO2, so you're hyperventilating them. You have a fast respiratory rate, so you really have to monitor these patients. H for hyperventilation, which is the whole basis for this. This is just where you have the excessive respirations and you're expelling the CO2, so just hyperventilating can cause it. Y for hysteria, the Y in hysteria, this is where you have anxiety. A patient's going into an anxiety attack. One of the hallmark signs of an anxiety attack is that they start just hyperventilating and they're getting very worked up. And again, this leads to the rapid breathing. They have the hyperventilation and they're just expelling all that CO2, so that's going to throw off their levels. Pain, P for pain. Whenever a patient's in pain, they're hurting, they're breathing fast, they have increased respiratory rate. So again, you're expelling the CO2. Pregnancy can cause this, especially if a woman is in the 3rd trimester of pregnancy, because you have the fetus that has moved up, it's up underneath that diaphragm. The respiratory tract has changed in the way that it's settled because you have this fetus up there, and that can lead to respiratory alkalosis and pneumonia. Okay, N for neurological injuries. Any injuries to the head that hurts the respiratory center, again, the medulla or the pons area, like with a head injury or a stroke, can cause a patient to go into respiratory alkalosis. E for embolism and edema in the lungs. And then A for asthma due to hyperventilation, because whenever a patient has asthma attack, they are hyperventilating sometimes, and this can cause them to blow off too much CO2. Okay, so now let's talk about how these patients are going to look, what you're going to do for the patient as the nurse, and then let's work a arterial blood gas problem with the patient in respiratory alkalosis. Okay, so how are these patients going to look to you as the nurse whenever they're in respiratory alkalosis? Okay, one of the most classic signs, if you can't remember any of the other signs and symptoms, is this. This patient is going to have a very fast respiratory rate. They are going to really just be breathing in and out hard. A rate greater than 20, but sometimes you're going to see it up in the 40s, just really hyperventilating. This, in turn, is going to cause them to be confused. They're going to be tired for breathing that fast. Their heart rate's also going to be increased because, they're really using some energy, so their heart rate's going to be high. Now, other signs and symptoms that you really, really want to remember are the following. Tetany, any EKG changes, muscle cramps, and positive Chavotsky sign. Does Chavotsky's ring a bell? Remember in the fluid electrolyte series when we were talking about calcium, whenever you have low calcium levels, you can have tetany, muscle cramps, and the positive Chavotsky sign. That's where you stimulate the masseter muscle at the jawline, tap that, and either the nose will twitch or the lips will twitch if the calcium level is low. And whenever you have respiratory alkalosis, this affects your calcium and potassium levels, and it decreases them. So they will exhibit signs, if they're really bad alkalotic, of hypocalcemia and hypokalemia. Now remember, in respiratory acidosis, it actually increased the potassium levels. So remember that, because a lot of test questions like to hit on that. So in alkalosis, it decreases calcium and potassium levels. But in acidosis, it increases your potassium level. Okay, so what are you going to do for this patient who is in respiratory alkalosis? Okay, you want to teach them breathing techniques. If they're having an anxiety attack, something like that, you want to have them slow their breathing down, hold their breath, get that breathing to slow down, or rebreathing in the paper bag. That helps them whenever they're blowing off that CO2 to inhale that CO2 again, hopefully to get those levels back up. Watch the potassium and calcium levels, and for those signs and symptoms of low potassium and calcium levels. And also, remember this is a big one. If the patient is on mechanical ventilation, because remember that was a cause of respiratory alkalosis, make sure that the settings are appropriate and they're not hyperventilating. So you'll want to watch out for that. Now let's solve.
Now we can finally go over the last one. Here we go, metabolic alkalosis.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video, I'm going to be going over metabolic alkalosis. In the next video, I'm going to be talking about metabolic acidosis. So if you're studying these, be sure to check out the other video, because I'm doing a series on acid and base imbalances. So in this video, what I'm going to do is I'm going to cover what metabolic acidosis is, how it's affecting the body. I'm going to go over the causes and give you a clever mnemonic on how to remember the causes. Then I'm going to go into the signs and symptoms, the nursing interventions, and work an ABG problem for you with a patient in metabolic alkalosis. Now after this video, be sure to go to my website, RegisteredNurseRN.com, and take the free quiz that will test your knowledge on metabolic acidosis and metabolic alkalosis. A quiz should be popping up, or a link in the description below. So let's get started. First thing we want to do is go over the key concepts of what metabolic alkalosis is, because if you can understand this, you can understand the causes, the signs and symptoms, and everything like that. Because for the NCLEX and as a nurse, you need to know the basics of what's going on so you can provide quality care to that patient and know what to look for. So in metabolic alkalosis, we have a metabolic problem going on. In the respiratory, we had respiratory issues. We had CO2 issues, buildup or depletion of CO2. But in metabolic, we're talking about bicarb, HCO3, which your kidneys are responsible for that. So what's happening whenever a patient is going into metabolic alkalosis, it's usually due to because the body has experienced an excessive loss of hydrogen ions, of acids. So the body has lost all these acids, hydrogen ions, which in turn has increased the bicarb. So whenever you're losing all that acid, the bicarb is going to go up. And it's the opposite in acidosis. What happens is you're losing all that bicarb and the acids are going up. The acids go up, causes the bicarb to go down. So this is the opposite. Or the body has increased in the production of the amount of bicarb it has, which we'll go over in depth over here, and you can see what's happening with each. So what happens whenever this happens, the body tries to compensate for that. It's like, hey, we need everything back to normal, so we need some other system in the body to correct this. And what happens is that the lungs start to kick in. And what they want to do is they want to cause hypoventilation, because they think that keeping these CO2 levels high, which is an acid, will help balance that alkalotic state you have going on in your body. So it's going to slow down your respirations, hypoventilation, in hopes of keeping that CO2, which is acid, in the body. So they're going to have respirations like less than 12. And in hope of doing that, it's going to make your bicarb come back down to normal. So what's going to happen in the body, this is what kind of labs you're going to have. You're going to have a blood pH, because remember, you have an excessive loss of acid, those hydrogen ions. Your pH is going to become alkalotic because it's not an acid, so now it's a base. So it's going to be greater than 7.45. A normal pH is 7.35 to 7.45. And your bicarb is going to shoot up. It's going to be greater than 26. A normal bicarb is 22 to 26. And your PaCO2 will either be super elevated, because remember, it's trying to keep that CO2 in the lungs, the acid in the lungs, to help balance the body out, or it'll be normal. So you have to watch those levels. And a normal PaCO2 is 35 to 45. So let's look at the causes. Now, to help you remember the causes, because in nursing school on the NCLEX, you may throw a scenario out at you and say the patient has this condition, this sign and symptoms going on. What do you expect the ABGs to look like, or something like that? So try to remember the mnemonic alkali. We're in alkalosis. And remember, for metabolic acidosis, we remembered acidotic. So for this one, let's remember alkali. Okay, A for aldosterone production, which is going to be excessive. And this is in the condition called hyperaldosteronism. Now think back to patho. What's happening whenever you got way too much aldosterone in the body? Well, what's happening is that your renin, angiotensin, aldosterone system is being activated, and what happens is that on your kidneys you have the adrenal cortex, and it starts releasing all of this aldosterone. And remember what aldosterone does. It causes the renal tubules to keep sodium, so you're keeping all this sodium in the body, but that causes you to lose all of these hydrogen ions. Also potassium, so you're losing all those hydrogen ions, and whenever you lose hydrogen ions, remember, when hydrogen ions go away, bicarb increases. So all of a sudden you have all this aldosterone being pumped into the body, you're keeping your sodium, you're peeing out your potassium, your hydrogen ions, you're getting rid of those, losing all these acids, and the bicarb starts to elevate, and your blood pH starts to become alkalotic. Okay, next one, L, loop diuretics. Any type of diuretic therapy, especially the loop diuretics, which is Lasix, and your thiazides, like HCTZ, hydrochlorothiazide. What happens is that the patient just starts urinating all the time, and they're wasting from all that urine all those hydrogen ions, like chloride. And again, whenever you lose all those hydrogen ions, the bicarb starts to increase. So you start to have alkalotic conditions. The blood pH starts to become alkalotic because you lost all those acids, and your bicarb increases. Okay, next, K. Remember the K in alkali ingestion. This is patients who've consumed way too many foods that are very alkalotic, like baking soda, antacids, milk, things like that. And what happens is that they take those into their stomach and eat those way too much, and enters the bloodstream and causes it to become very alkalotic, because those substances are very alkalotic themselves. Okay, next, the A for anticoagulant known as citrate. Citrate is actually used in the storage of blood, the blood bags that you get for transfusion. So if a patient gets a massive transfusion of blood and citrate is used as the storing agent, they're at risk for bicarb, which I'll go into why in a second. And patients who are on continuous forms of renal replacement therapy. This is an alternative form of hemodialysis that is a lot more gentler on the patient who may not be hemodynamically stable to do dialysis, and what's used is citrate as one of the things in that therapy. And what citrate does is the body looks at citrate and it metabolizes it as bicarb. So here's all this citrate going into your body either through the blood transfusion or the continual renal therapy, replacement therapy, and your body starts to metabolize that as bicarb. So that dramatically increases your bicarb levels. So any of that. Okay, next, L, remember this one, this is another very, very, very important cause. Loss of fluids, any severe vomiting or NG suction. And these fluids, your vomit, all that, and your NG, which is your GI stomach fluids, are very rich in those hydrogen ions, like potassium. So whenever you're just getting rid of those, either throwing them up or it's coming through the NG tube, you're suctioning all those out, the patient is very much at risk for metabolic alkalosis, because those are hydrogen ions that you're removing from the body. When hydrogen ions leave the body, the bicarb likes to go up. So remember that. And the last one, I, for increased sodium bicarb administration. Sometimes physicians may order sodium bicarb if a patient's a metabolic acidosis to help stable out that condition, but you can also give them way too much of it and put them in alkalosis, so it's a seesaw of a balancing act. Okay, so how do these patients present? What do they look like to you as a nurse who are in metabolic alkalosis? One thing is that they're going to have bradypnea if the body is trying to compensate. Remember, the body's going to slow down that breathing to keep that CO2 in there, which is acidotic in the body, because the body is alkalotic. It's too basic. So the lungs are going to slow down the rate of breathing to conserve that CO2. They don't want to breathe that much out. So you may have respirations of less than 12 breaths per minute. Also, you're going to have some symptoms of hypokalemia. And if you notice, in a lot of these causes, you're losing a lot of hydrogen ions, potassium. So whenever you're doing that, you're going into hypokalemia. So a lot of your symptoms you're going to be seeing are hypokalemic symptoms, like tetany, tremors, muscle weakness, tired, EKG changes. And remember, we talked about this in the hypokalemia fluid and electrolyte video, where the patient may have some depressed ST segments, flat inverted T waves, or prominent U waves. So now let's talk about the nursing interventions and work an arterial blood gas problem that you may encounter on the NCLEX exam or on your nursing lecture exams. So what are you going to do for this patient who is in metabolic alkalosis? Just like metabolic acidosis, you are going to treat the cause because there's various causes that cause this. So the patient's vomiting, you are going to give the prescribed antiemetic like Zofran, Phenergan to help them stop from throwing up, because remember, vomit is rich in hydrogen ions, and you get rid of that, you're going to make the body alkalotic and the bicarb's going to go up. And stop suctioning, especially the NG suctioning. You want to remember that because that's a lot of exam questions. And if they do have NG suction, make sure you're watching how much you're removing from the body in the suction container. Okay, next, stop diuretics. Because those diuretics like Lasix, your loop diuretics, you want to remember that, and your thiazides, if patients on that and their ABGs are showing metabolic acidosis, you want to stop those, and you want to watch that potassium and chloride levels because you're wasting a lot of those hydrogen ions through the urine. And watch their arterial blood gases, because remember, they're trying to keep the PaCO2, the carbon dioxide. So their levels can go greater than 45, and if they go too high, they may go into respiratory distress. They're going to be bradypnea. They may need to be intubated. So you want to definitely watch those levels. And the doctors, in some cases, may order Diamox. We talked about this in acidosis. Diamox can cause metabolic acidosis because it's one of those carbonic anhydrase inhibitors, which reduces reabsorption of HCO3, which is bicarb, but this is actually used sometimes to treat it. But you have to watch out because this is a diuretic and it can cause hypokalemia. So watch that. You want to look at your potassium levels before you give that. So that is some nursing interventions. Now let's work an arterial blood gas.
Well, that's everything right there. Pretty easy, not too bad.